So hello everybody, in this video we will be discussing about the variation of blood pressure with respiration, and also we will be discussing about the renal regulation of blood pressure. So what happens when we inspire? Let's first understand the concept. When we are inspiring, our diaphragm is going downwards and our rib cage is moving forward, and as a result of which there is a negative intrathoracic pressure. Because of this negative intrathoracic pressure, blood from the peripheries will rush towards the heart via the vena cava. The venous return to the right atrial chamber will increase. The right ventricular output will also increase. But the blood going from the right ventricle to the pulmonary vasculature will get damped once it reaches the lungs over there, and it will find difficulty to pass from the pulmonary vasculature back to the left atrium. All of this is because of the negative intrathoracic pressure. As a result, due to decreased left atrial return, the left ventricular output will also decrease, and a decreased left ventricular output will result in a decreased blood pressure. And because of this phenomenon, one important thing also occurs, and that is the A2-P2 split of the second heart sound, and that is the A2 or the aortic valves will close at an earlier time than the pulmonary valves, obviously because it has this less blood to pump out. Now let's understand this a little bit diagrammatically. Over here we have the four cardiac chambers. These are the two lungs. This is the pulmonary circulation. This is the systemic circulation. The green dotted line is the thoracic cavity, and the orange line is the diaphragm. So we can see that when we are inspiring, the right atrial return is increasing, the right ventricular output is increasing. However, the left atrial return has decreased, and consequently the left ventricular output has also decreased, resulting in a decreased blood pressure when we are inspiring. However, when we are expiring, all this blood will rush back to the left atrium and the blood pressure will increase. These are two graphs which are depicting the same. The first one shows the PaCO2, that is the partial pressure of carbon dioxide versus time curve. You can see that it reaches a peak just before we inspire, and then it falls and again starts to rise as we are expiring. Consequently, during inspiration we can see that the blood pressure has fallen, and in expiratory phase it is increasing. However, one thing I'd like all of you to note is that the diastolic blood pressure is maintaining the same level. However, the systolic blood pressure has varied. This is because the peripheral vascular tone is remaining mostly unchanged, and this increased diastolic blood pressure will result in an increased stroke volume during expiration. Okay. Now, one thing all of us should learn, especially since we are discussing about the variation of blood pressure with respiration, and that is the Valsalva maneuver. Now, what is the Valsalva maneuver? We typically encounter this when we are forcefully trying to defecate. That is when we are straining against a closed glottis. So what happens is that our intrathoracic pressure increases, okay, and this gets added onto our left ventricular outflow, and as a result the blood pressure is increasing initially. Now this increased intrathoracic pressure will finally result in the collapse of the inferior vena cava, which are returning blood to the heart. Due to decreased venous return, the left ventricular output will then fall, resulting in a decreased blood pressure. At this moment, corrective mechanisms initiated by the baroreceptor reflex will come into action, and then it will increase, but ultimately there will be a fall, because there is an extent up to which the baroreceptor activity can correct the blood pressure. And so this is what is depicted graphically in this blood pressure versus time curve. The peaks over here represent the systolic blood pressure, and the minimas over here they represent the diastolic blood pressure, and this dotted line traced throughout the curve is what is the mean arterial pressure. And you can see that the mean arterial pressure is fluctuating, and these are the points where various mechanisms are acting. Okay. And where do we use this Valsalva maneuver? One is we use when we are trying to pop open our ears. We use it when you're trying to lift weights. I told it already that when we're trying to forcefully defecate. However, one important therapeutic indication is it can help to decrease the heart rate in some tachycardic patients as well. Now this is because when this increased intrathoracic pressure increases the blood pressure of the individual, reflex bradycardia will occur, mediated by the baroreceptors, and this can help to reduce the heart rate. Over here I will be discussing two important charts which are commonly given in our practical exams. One is the respiratory waves or the Traub-Herring waves of blood pressure, and the next is the Myers waves. What are these respiratory waves? These go something like this. Okay. The small changes, the incisura, all of these cannot be measured. This is actually a chymographic tracing, and hence the two inferences which we can draw from this is that the peak over here will be representing the systolic blood pressure, and the minimas over here will be representing the diastolic blood pressure, and a dotted line which is drawn throughout the curve will represent the mean arterial pressure. Okay, now from our previous discussion you can understand that this ascending limb, that is when the blood pressure, the mean arterial pressure is increasing, will be encountered during expiration, and this descending limb, when the blood pressure is falling, will be encountered during inspiration. However, I want to draw your attention to this one fact. When we are expiring, you can see that these curves are moving further and further apart. However, when we are inspiring, these curves are coming closer to each other. Distance between the two curves is a measure of the heart rate of the individual, and so during expiration our heart rate falls. Why is this? This is because of the reflex bradycardia initiated by the baroreceptor reflex, and hence the same mechanism will also operate when we are inspiring, resulting in an increased heart rate. This is an evidence of a very important cardiovascular physiology law, and that is the Mary's law, which states that the blood pressure is always inversely proportional to heart rate. But this is not universal. There are exceptions, the most important of which is during exercise or anxiety, where both our blood pressure and heart rate will increase, and also the Bainbridge reflex. Interesting anecdote, during an episode of fear, when you're feeling afraid, our heart rate decreases. It doesn't increase. Okay. Now what are the Myers waves of blood pressure? These are small regular oscillations of arterial blood pressure which occur as a result of sympathetic nervous activity. Okay, and these occur at the rate of 1 every 20 to 40 seconds. Over here you can see that these are the normal Traub-Herring Traub-Herring waveforms, and the small deviations which occur regularly, these are the Myers waves. Physiologically, they are encountered in a hypotensive patient where the chemoreceptor reflex is operating frequently, and in those situations these Myers waves will occur regularly or at increased frequency. One important tip is that suppose an examiner asks you that how will you be calculating the mean arterial pressure, the blood pressure from a Traub-Herring waveform. You will say that you will simply draw a mean line through these curves. You will measure the distance of this line from the baseline, provided whatever value you will get, you multiply it by 2 and you will get your mean arterial pressure. Okay, and this multiplicative factor is arising from the grading of the y-axis. Now let's finally move on to the renal regulation of blood pressure. So let's approach this in a very conceptual manner. This is a graph plotted for volume versus blood pressure. Volume will be denoting two things. Number one is the salt water intake of the individual, and which is noted by this yellow line, and this orange line will be denoting the urine output. Okay, so this yellow line which you can see is a straight line, so we are assuming that the individual has an uniform salt and water intake. I want to draw your focus to over here. So irrespective of the salt water intake of the individual, if the blood pressure of the individual is not exceeding 50 millimeters of mercury, there will be no urine output for that individual. However, with increasing blood pressure, the urine output will be increasing. The point where these two meet is known as the equilibrium point. That is where the salt water intake equalizes the urine output, and at this point the blood pressure will be maintained at a mean value that is around 100 millimeters of mercury. Now suppose somebody's blood pressure has shot up to, let's say, 150. So it is in this portion of the two curves. In this portion, the urine output is exceeding the salt water intake. Now what is the net result of this? If your output is more than the input, obviously there is a loss. So here there is fluid loss, and the blood pressure will consequently fall. Now suppose your blood pressure is around 75 millimeters of mercury. So it is in this portion of the curve. Over here your intake, salt water intake, is exceeding your urine output. So input is exceeding output. So you will have a fluid retention, and this will ultimately lead to an increase in blood pressure. I hope you are getting the point. Therefore, two mechanisms to increase the blood pressure would be either to shift the urine output curve to the right or the salt water intake curve upwards. Both occurring simultaneously is a rare phenomenon because some compensatory mechanism will come into action to cancel out one of them. Okay. So finally we are coming to the most important part and the last slide of this module, and that is the renin-angiotensin-aldosterone system. So we all know about the GG cells, which are located in the walls of the afferent arterioles. These are very strongly stimulated by, in case of renal hypoperfusion, that is whenever the blood pressure has fallen or whenever the cardiac output has fallen. Other stimuli for this is beta-1 adrenergic agonism or prostaglandin stimulation. In the GG cells, prorenin will be cleaved to renin and will be released into the circulation. Renin will be cleaving this circulatory biomolecule called angiotensinogen, which is synthesized by the liver from angiotensin 1. Angiotensin 1 is converted by angiotensin converting enzyme, which is found in the pulmonary vasculature, to angiotensin 2. Now angiotensin 2 has three main receptors, AT1, AT2 and ATX. ATX because its function hasn't yet been determined. AT1 agonism, this is the one which we are concerned about. It causes vasoconstriction and also aldosterone release. AT2 agonism, on the other hand, will cause vasodilatation, natriuresis, that is loss of sodium and water via urine, and also will inhibit cell growth. So this is a very beneficial effect. However, angiotensin 2 has a less affinity towards AT2 receptors rather than AT1 receptors. Angiotensin 2 can further be converted to angiotensin 3 and then angiotensin 4 via aminopeptidases. Angiotensin 3 will also act on these three receptors, but albeit with a lesser affinity, and hence a lesser physiological effect will be exerted. AT4 analogs, these are very interesting because angiotensin 4 analogs have shown to increase neurocognitive abilities in Alzheimer's patients, and they are currently under trial. Okay, so let's come back to angiotensin 2. Before that, angiotensin 1 is also acted upon by another enzyme called angiotensin converting enzyme type 2 to form AT1-9. Now AT1-9 can also be converted by angiotensin converting enzyme to angiotensins 1 to 7. Okay. Now angiotensin 1 can also be converted to angiotensin 2 by a minor pathway which is known as kinase. So why is this important? You know that for a long time a very gold standard approach to treat hypertension was to prescribe angiotensin converting enzyme inhibitors like captopril, ramipril, perindopril, lisinopril. However, as we slowly come to understand that there is this minor pathway always operating, obviously minor because it's not that well established in all organs of the body, but nonetheless it is operating. There will be always some amount of angiotensin 2 which is being found, which is acting on these angiotensin 1 receptors to cause an increased blood pressure. So angiotensin converting enzyme for the treatment of hypertension are slowly going out of favor and are replaced by AT1 blockers like telmisartan, valsartan, losartan. So these hasilsartan. So these AT1 blockers are slowly replacing the use of ACE inhibitors. Okay. Now coming back to angiotensin 2, what are the effects of angiotensin 2? Number one is that it causes efferent and afferent arteriolar constriction. However, efferent constriction will be more than the afferent. This is because of the afferent arteriolar side, there will be actually little amount of nitric oxide and prostaglandin release, which will counteract the effects of angiotensin 2 to cause a little bit of dilatation. But angiotensin 2 is a very strong vasoconstriction, so its effect will be only a bit nullified, and hence the efferent arterial constriction will exceed the afferent arterial constriction. This will result in increased filtration fraction, which will result in increased peritubular capillary colloid osmotic pressure. As a result, there will be sodium reabsorption from the PCT, and hence there will be decreased salt and water excretion. Also, angiotensin 2 will decrease vasorectal blood flow. If you have already completed your renal physiology, you will understand that decreased vasorectal blood flow will increase an urea concentration in the interstitium and cause a decreased sodium concentration in the interstitium. It will cause salt and water reabsorption, resulting in decreased sodium and water excretion. Increased salt and water retention will ultimately lead to an increased blood pressure. Angiotensin 2 will also stimulate aldosterone release. Aldosterone will act on the principal cells of the collecting ducts to cause sodium and water retention. And finally, one more effect of angiotensin 2 which is not discussed often is that it also stimulates the osmoreceptors present in our brain. These are located commonly in certain regions called OVLT. There is organum vasculosum of lamina terminalis, and SFO, there is subfornical organ. You will learn more about these in your CNS portion. Stimulation of osmoreceptors in these areas will cause a feeling of thirst in the person, and as a result the person will drink water and the blood pressure will slowly start to climb up. So that's that. I hope you enjoyed this module. If you have any queries, please pause the video, go back, listen to it again. I'm going a bit fast because I'm trying to keep the modules as short as concise as possible. If you have any queries, you can also put them in the comment section, and I'll try to address them to the best of my abilities. Thank you.